Hi, everybody. No gifts for you, I'm sorry. All right. I think we can all agree that health departments are a really important focus for ending the HIV epidemic in the U.S. They are the coordinating body for EHE plans at the state and local level. They fund, oversee, and often are implementing or delivering the EHE interventions. And in many respects, they are the target for the learnings from the EHE-supported implementation research that we have been so diligently working on. And to say that the budget or the size of resources going to EHE jurisdictions is outweighed compared to what is going into research, as it should be, would be an honest statement. So today we'll be focusing on how academic and public health partnerships can be developed and supported. My name is Kenneth Sherr. I'm a professor from the University of Washington in Seattle, not one of the other Washingtons. And I direct our implementation science core at our Center for AIDS Research, as well as lead the RAISE hub, which is one of the 8 consultative implementation science consultation hubs that are supported at a regional level through EHE. And what I'd like to talk about, just briefly, if I can get a bit of your time, is some work that we have been carrying out with the National Alliance for State and Territorial AIDS Directors, or NASDAD, to try and build out a platform for working with health departments and supporting the integration of implementation research into health department work. So just quickly about RAISE, as I mentioned, RAISE is one of the 8 regional consultative hubs supported through EHE. It's the Research Alliance in Implementation Science to End HIV. It began receiving support as a supplement through our CFAR in 2002. And like all consultative hubs, we are focusing on aim 1, supporting EHE-funded research to build out implementation science tools, methods, strategies. A second aim to work on cross-site research, but unique from other hubs is that we developed a partnership with NASDAD to build a platform in the context of local EHE activities to integrate implementation science into health department work. So I just briefly want to talk about what we've been doing with NASDAD and what our plans are for the next year. We're funded through May of 2025. So the first is that we have a monthly webinar series. We've had 12 virtual webinar events with quite high attendance, almost 1,000 participants to date. And 2/3 of the participants are from local and state health jurisdictions across 46 states. So pretty high reach. You can access all of these webinars on our YouTube channel. We'll be continuing these webinars for the next year and really try and highlight academic and public health speakers and to bring tools around implementation science to practitioners in the health departments. I would say that, as I mentioned, this will be continuing. So if you are in a health department, please join these webinars. Or if you have others that work at health departments, please let them know about this. NASDAD has been doing an incredible job of advertising these events to health department staff. Now, second is we carried out a needs assessment in 2023 to try and identify what are some of the current capabilities, what are the interest levels across health departments, and what can we do to build more capabilities in the area of implementation research. And so we had 15 health departments respond to our survey. It was responded to by a host of different representatives from health departments. And we found a couple of things. Well, first is that EHE plans currently include identification of implementation determinants and testing of novel implementation strategies, although the evaluation plans were inconsistent across these different EHE plans. There was a lot of interest in economic analyses, but not a lot going on in terms of integrating economic evaluations into EHE plans. And that most EHE teams already were partnering with some sort of academic or research institution, which is quite encouraging, and that interest was relatively high in implementation science, and wanted to learn more through webinars, through protocols or templates that could be shared for evaluating activities and peer-to-peer learning. So we have developed a training, which will be an in-person training for health department staff, which will be next month, where we're focusing on building capabilities through didactic training for implementation research. There'll be a hands-on component to develop a specific plan for participants around evaluating the program, EHE program or a particular activity in the EHE plans, and then to build a network through peer-to-peer learning. So we'll have 15 health department representatives joining us in this training next month. This will be repeated in 2025, probably in May as well. And just say there was much more interest in participating in this training than we had slots for. So this is an area of high interest and need, and we'll be continuing to work to foster these relationships. Now on to the main event. We have 4 great speakers who will be joining us today. First is Stephen Bonett, who is a public health nurse researcher and an assistant professor in the Department of Family and Community Health at the University of Pennsylvania School of Nursing. His research focuses on identifying and addressing structural barriers to public health service delivery through community-partnered research that employs implementation science methods with a health equity framework. Second, we have Susanne Doblecki-Lewis, who is a professor of clinical medicine and chief of the Division of Infectious Diseases at the University of Miami. And she also works at Jackson Memorial Hospital at the University of Miami. Her clinical research focus is on improving access to HIV and infectious disease prevention strategies for underserved populations. Third, we have Raphael Landowitz, who is a professor of medicine, interim chief of the Division of Infectious Diseases, and center co-director of the UCLA CHIPTS. He also serves as director of the UCLA Center for Clinical AIDS Research and Education. He's an ID, infectious disease and HIV clinician with a clinical and research interest in HIV and STI prevention. And last but not least, we have Wendy Garland, who is chief epidemiologist with the Division of HIV and STD programs at LA County Department of Public Health. She currently oversees the monitoring and evaluation of county-supported HIV and STD prevention and treatment services, including innovative service models supported through EHE. So, welcome everybody. I think, Stephen, you're gonna go first, right?
Awesome. Good morning, everyone. I'm giving it a test drive. All right, the slides work. I'm really excited to get to talk to you all here today. I'm going to talk about a project that we worked on that was a partnership with the Philadelphia Department of Public Health and our team of researchers at the University of Pennsylvania. Before I get into it, I want to actually give a little bit of context about our team and who worked on it. There's a couple of names on this slide that I want to highlight. My name is there, but importantly, Javante Williams' name is there. He was an instrumental partner from the Philadelphia Department of Public Health. He's the director of prevention programming there. He was unable to make it to this meeting today. He's very busy with his work at the health department, but I want to make sure that his contributions to this work and to helping me put together the slides are acknowledged. Couldn't have done this without him. There's also someone whose name should be on this slide. Jose Bauermeister was the PI of this project, and I realized last night, I was like, I probably should have put his name on those slides. So lots of credit to Jose, but I'm very honored that I get to present the work, but let me not take all the credit for it. So give a little background to what the motivating kind of impetus behind this project was. And I think this is right in line with the conversations that we had yesterday. We know that we need to scale up access to comprehensive and, very importantly, culturally competent HIV prevention services. And that really means that we need to think about working with communities and especially within community-based organizations. And so that kind of idea led to the development of actually 2 subsequent EHE supplement projects. The first one was a formative research project that looked at the EHE or the HIV workforce in Philadelphia. So these were folks working in community-based organizations that were funded by the health department across the city. And the learnings that we got from that EHE supplement were what drove the one that I'm going to talk to you about today, which is focused on capacity building and workforce development in these CBOs that are funded by the health department. So what we learned from that first EHE supplement when speaking with folks working in the CBOs was that there were, first of all, there's a pretty big and diverse HIV prevention and treatment workforce in Philadelphia. But as we kind of got into the nitty-gritty of the specific knowledge and information around HIV, we found gaps in knowledge, and especially related to PrEP. And so this was in like 2019, so a few years back now, but it was the impetus to say, oh, we need to think about potentially building up the workforce and bringing in education and resources to these spaces across Philadelphia. The other big thing that came out of that formative work was that the folks we talked to, the people working as test counselors, as prep navigators, said that there is a definite need for more cultural competency training, specifically when thinking about working with young sexual and gender minorities, and how to talk about sexual health and HIV and STI prevention. We also talked a lot about greater cultural competency around mental health and substance use. And so that was kind of the theme from these conversations. Folks said, we are serving a lot of folks, but we sometimes do not feel perfectly equipped for that. So training would be a big, big benefit and a big asset for these folks in these work environments. So this EHE supplement was built around the idea of, can we implement a systems level intervention? So can we bring resources and education to these CBOs, responding to exactly what they said they needed to strengthen the workforce and improve the delivery of HIV prevention services. So that was the idea. We're going to work with 10 CBOs across Philadelphia that are funded by the health department, and we were going to implement this systems level intervention. I'm going to tell you what the plan was, and then I'm going to tell you what actually happened. This happened this was 2020, 2021. This was right as the COVID pandemic was happening. So the idea was that we wanted to work with the health department and with our stakeholders in the city to develop a workforce training curriculum that would address some of those gaps that had previously been identified. We were going to do this super clean, randomized, stepped wedge cluster design. It was going to be great. There was multiple components that included site visits, webinars, in-person trainings, and then like personalized technical assistance going back to the agencies afterwards. That all sounded really good in 2019, but in 2020, a lot of that actually became quite impossible due to the restrictions around in-person gatherings. So we had to make some alterations and we had to make some adaptations. And I want to highlight how this happened in concert and like in constant communication with the health department, right? So our health department partners were all helping us to drive these adaptations and say, okay, what is possible? We still are going to do this. We need to figure out how we're going to do it though. So rather than a stepped wedge design, we said, let's beef up and expand the health department's kind of existing training curriculum for all of the folks who work in their funded agencies. And so they said, we want to actually put together a series of modular webinars that can be deployed kind of ad hoc and as needed to different agencies and for different roles. So that sounds great. We kind of get rid of the on-site training because that was no longer possible. But we say, oh, that gives us additional flexibility in terms of being able to develop actually more content and make it potentially more flexible and easy to access for folks. So like I said, these webinars were modular, right? They were not day-long webinars. They were like 1-hour webinars, 90-minute webinars. So things that could be kind of pieced together, and a training curriculum could be developed for a specific agency and for a specific role based on whatever the need in that agency was. There's also some other changes from the kind of administration of the funds that were going out to the CBOs. The health department was implementing their community plan to end the HIV epidemic, and that included new priorities. And that meant that the funding structure for the CBOs changed a little bit. The new focus was on low threshold sexual health centers. So this was really great, but it meant that the mission of the funded agencies changed a little bit. And then there was also community mobilization agencies. So all this means is that the webinars were actually really tailored to say, let's make sure we get the right trainings to the right agencies. I'll give you just a preview of what these webinars look like. These are the topics. The ones that I've bolded are the ones that our team at Penn Nursing either helped design or brought in consultants to help design. The ones that are not bolded were actually already existing at the health department. And so we kind of worked together to say, let's expand and enhance this portfolio of webinars that can then be deployed at the different agencies. And you can see that a lot of these speak directly to those gaps that were identified in the first EHE supplement, including serving LGBTQ communities, thinking about people who are using injection drugs, and incorporating kind of harm reduction principles, and then thinking about trauma-informed care and bringing in a mental health perspective. Okay, so I'm going to very quickly look at the results of this study. You can see that we surveyed folks from across these agencies and from across various roles. So we talked to people who were HIV testers, PrEP counselors, a lot of people who had direct client interaction. So that also included people who kind of worked at intake and front desk, as well as administration. And then we also talked to folks who were in higher up agency leadership. So we had a diversity of perspectives here. Oh, another thing I'll just quickly highlight here. A lot of these folks have worked in the field of HIV prevention and treatment for many, many years. So these organizations are oftentimes very long-standing and have folks with a ton of experience working there. We got kind of satisfaction and completion data on the trainings. The short version of this story is people said they really liked the trainings, but they did not really complete the trainings. The median completion rate was 50%. So we found that people were actually not doing these webinars as assigned. They were doing some of them, and the ones that they did, they said they loved. But I think that's an important take-home point right here, is that we were seeing much lower completion rate than we expected. We have some data on the kind of implementation science, acceptability, appropriateness, and feasibility measures. What we were interested in was to see if there were differences by role in how these trainings were landing for folks. You say you love them, are different people loving them to different degrees? We found that yes, kind of. The only real takeaway here is that agency leadership kind of consistently had lower ratings of acceptability and appropriateness than the frontline staff. So we think that the way the trainings were designed, we're landing a little bit better with folks who have direct client interaction, and the folks in leadership who are also taking these trainings, not resonating with them as much. So this is the same analysis, but 3 months after the trainings. The trends are very similar, though. Basically, no big differences except for agency leadership has lower acceptability. This is the kind of main outcome of the intervention. Did it improve people's cultural? These are some cultural competency and like workforce duty and knowledge, and some of those things that we were trying to move with this intervention. They did not move from baseline to follow-up, and I'll just highlight, I think we're seeing a ceiling effect here. People had very high scores on these measures at the beginning. They had high scores at the end, so we really were not seeing movement on these measures. Really quickly, we hypothesized that this could be because some people did the trainings and some people didn't. Surprisingly, when we stratify by engagement, there is also no difference. So it is not just the folks who did the trainings had movement on the outcomes, but rather it seems no one was really moving on the outcomes. So what does this mean? I have 15 seconds, and I'm gonna try to encapsulate our take-homes. There are major challenges to this kind of webinar-based training. There's questions about how can we mandate and get buy-in from staff to say, you really should take these trainings, and please do them. And then also the question of, was the content really relevant and resonating? And because from our qualitative work, we found that some staff felt that some of this was redundant and duplicative, potentially because they have 10 to 15 years of experience in this field. And so I think that's a lesson we can take forward. The other thing I just want to highlight before I give up the mic here was that despite the fact that this was not moving the outcomes we wanted to, in our conversations with the health department, our takeaways are that there are definitely lessons learned here that we want to take forward, and the modular training despite the fact that they had some shortcomings, were so flexible and convenient that they will continue to use this platform going forward. And the next step will kind of be, how can we continue to improve and adapt? But the idea, we think, is still very good, and we want to continue to move forward with it. I'm going to stop there, and I'll look forward to speaking with you all and doing some questions in the answering session.
Thank you, Stephen. You're up.
Okay, good morning. Susanne Doblecki-Lewis from the University of Miami, presenting on work with our public health collaborators at Miami-Dade County Health Department, Kira Villamasar, who unfortunately is not able to be here today, as well as our partners at the Florida Department of Health in Tallahassee, Claudia Sanchez currently, and previous to her, Mara Mishnevitz and Emma Spencer. You'll see their input and work throughout this presentation. But unfortunately, they weren't able to be here to participate in person. My disclosures, we do get research support for clinical trials in our clinical research unit from Gilead and Merck. And I want to start with an introduction and kind of an origin story for our mobile PrEP clinic. I've been working with our health department in Miami-Dade since 2012, which is when that health department STI clinic was a site for the PrEP demo project. And then after that, I helped to set up and run the health department's PrEP clinic within their STI clinic. And I realized through that this was a very important clinic, but it also became clear that there were a lot of people we were not reaching, we would never reach, and would never come to that clinic. So we began working at that point with community advocates, and particularly the community-based organization Prevention 305, which focused on community-centered PrEP navigation. And they were finding many barriers to navigating clients to clinics and providers, and that were able to meet their needs. So together, we realized the need to disrupt PrEP care in Miami and to create from the ground up a new strategy for PrEP delivery that was convenient, client-centered, and outside of a traditional clinic setting. And the goal was to be able to overcome multiple barriers to PrEP all at once. And so this became the concept of the mobile clinic. We started the mobile clinic in 2018 with support from the Florida Department of Health, the Miami-Dade County Health Department, the City of Miami Beach, and our flagship site, which is the Hotel Gathering in South Beach. And a vehicle which was actually borrowed from our cancer center. This is not the vehicle we had in 2018. That's the vehicle we have now. And we had, in the first year, 250 PrEP starts, and we grew to the point that we established in 2020 a fixed clinic to support our mobile clinic. And we've since added additional services such as NPEP, STI treatments, injectables, and rapid entry into HIV care. So the mobile clinic goes to 5 sites, and each of them are in a distinct community in Miami-Dade. Miami-Dade is really a patchwork of communities that are often quite distinct from each other. And we selected these sites based on incidence data and community input about where services were needed. So you can see the summary here. So moving on to our EHE supplement. So that was 2018 that we started the mobile clinic. And in 2019, we received the first EHE supplement, which was, the intention was to work with the health department and community partners in order to develop a workflow to go from epidemiologic and molecular HIV cluster data to community outreach and mobilization to provide services in neighborhoods and communities that were identified through the analysis, and ultimately to interrupt transmissions. So here's a summary of those activities from the first supplement. So we did establish the workflow and the collaboration, which has been fantastic. We continue that collaboration, and we meet with our health department partners to review data every quarter. We established, based on the data and the intention of the first supplement, we established a new mobile PrEP site in the Liberty City neighborhood in September 2020, which was quite an effort. We're really very much in the midst of COVID. And leading up to that, and again as part of the supplement, we had done a number of community consultations to think about different methods of outreach as we reach into new neighborhoods and as we bring new sites on board. So some of the things that came up in those consultations were that HIV prevention was a recognized priority in many of the neighborhoods. Some preferred in-person outreach. A lot of our outreach up to that point had been based on either in sort of word of mouth from our clients, or with our partners, Prevention 305, a lot of what they did was based on apps and social media. So we realized the need to extend our outreach in different ways. Also, we heard about many failed attempts accessing services and often a feeling of futility. The need to establish trust through partnerships and follow through. A recommendation to focus on STI testing and treatment to enable PrEP education and so that people could start PrEP when they were ready. And to build support, engagement, and motivation through established trusted sources, including close peers and community resources. So based on those recommendations, we received a second EHE supplement in 2020, which was called Adaptation of the Mobile PrEP Toolkit. So essentially, we propose to continue our current barrier-lowering strategy with the core elements that are listed here on the left, and then to add additional toolkit elements, including the best possible positioning data, multiple outreach strategies, also a pre-visit strengths-based navigation program from local neighborhood testing programs. I will say that was very difficult and didn't really happen during COVID. Peer advocacy and engagement for HIV testing and prevention, and social network engagement. So I'm going to focus on the social network engagement. So we started working with Mariano Kanamori, who you heard from yesterday, as well as Ariana Johnson, who's here in the room, and developed a social network strategy that we called Test to PrEP. So this is a strategy to empower current PrEP users in Miami to engage people in their social networks in HIV self-testing and to provide PrEP resources. It was actually based on a pilot that we had done a couple of years before with the health department on distribution of HIV self-test kits. And so we had done some assessment of whether people wanted to do this, and they definitely did and were enthusiastic about it. And we had some early success with that. So with the supplement, we did some additional development of the kit with community input and evaluated the organizational and community determinants of implementation using the CFAR. So just to summarize the distribution of the kits, we identified 100 clients, and they then in turn identified 414 social network contacts. They received a brief training, and then they were offered up to 4 HIV self-test kits bundled with this customized package of resources. They accepted a median of 3 kits, and we did a 3-month telephone follow-up with our clients. We also put a unique QR code on the test kits and the offer of a $10 incentive for people who would complete the survey after they did the test. So in our implementation evaluation, we found that Test to PrEP is doable, and our clients are mostly very interested in this strategy, actually. And everyone who we surveyed felt completely or mostly comfortable with distributing the kits. We didn't identify any safety concerns or issues. And I think this is interesting, 77 reported discussing PrEP with the recipient of a kit. We also had some qualitative data, and people thought it was a great way to reduce stigma around testing, and were excited for the opportunity to help their friends who hadn't been tested before. And in terms of the people who completed the survey, we did have 2 reactive tests, engaged in care. One was a false positive, but did start PrEP, so I think that's a win. 4 PrEP starts directly traced to the kits. Of people who responded, 38% had never heard of PrEP before, and 17% had never tested for HIV previously. And they reported a median of 3 sex partners in the last year. And we did see an increase in the likelihood to take PrEP scale. And interesting, looking at who were the most effective or efficient distributors of the kits, we found that it was often people who were new PrEP starts. And I guess more obviously, people who had identified more social network contacts in the initial interview. So getting back to where our program is now, mobile PrEP in general, and now with the add-on of our fixed clinic, it started in 2020 to support mobile PrEP. We have about 2,500 clients. We've had a little over 1,300 PrEP starts. We have done injectables. Happy to talk about that. Could be a whole nother talk. The median age is about 37, and the majority of our clients are a Latino MSM, with about a quarter identifying as Black or African American, and most were born outside of the United States. Our rate of new HIV diagnosis at first visit is 3.2%, and we have a little less than 20% positivity rate for acute bacterial STIs at the first visit. So getting back to the equitable reach component, which has been a little difficult to measure, honestly, because of the disruption in the data during COVID. But here's a summary of the data from our mobile and fixed clinic I've highlighted on the left. And I'd like to point out that the demographics of people seen in the mobile clinic are quite different from those who come to the fixed clinic. This may be obvious, and it really reflects the demographics of the neighborhoods that we're going to. So just pointing out that you get different people engaged when you actually go to the neighborhood versus waiting for people to come to the clinic. We had a higher portion of women and people who identify as Black or African American in the mobile clinic, and a higher proportion of Latino MSM in the fixed clinic. And then one possible measure of equity is looking at how our demographics compare with the demographics of new HIV infections in Miami-Dade County. And what we see is that the combination of mobile and fixed clinics together gets us closer to matching those demographics, but there are still gaps, especially when we look at who is starting PrEP. So in conclusion, mobile clinic services for HIV prevention and treatment are feasible and acceptable to diverse communities in Miami-Dade County. Developing a workflow with the Department of Health allowed database positioning, and mobile clinics can increase equitable reach of HIV prevention services. Social network strategies, I think, are promising for further increasing the reach of HIV testing and PrEP. And then we were asked to comment on sustainability and future directions. So just to say some of the things that happened along the way, in 2019, we established a 340B pharmacy program specifically to support the mobile clinic, and that's been very helpful. In 2020, we also had HRSA and CDC funding for rapid start in the clinic and in the field. We have continuing collaborations with the Florida Department of Health, Miami-Dade County Health Department, and our community partners. And we're looking forward to adapting this toolkit for other EHE areas and also testing further our test to PrEP strategy. So lots of people to thank, and of course my amazing mobile PrEP team, and thank you for your attention.
Good morning. I'm Rafi Landovitz here from University of California, Los Angeles. I'm also co-director of CHIPS, so I'd like to add my welcome to all of you that I didn't get to meet yesterday to Stephen Wen's welcome. I'm also part of the UCLA-CDU CFAR as well, so we're in many hats today. I also need a disclaimer here. I am not an implementation scientist, so if you will, if this is a reality TV show of implementation science, call it The Real Housewives of EHE. I'm Andy Cohen, and this is Watch What Happens Live. Okay, I'm presenting on behalf of the TIPS study team, which is a collaboration between UCLA CHIPTS, the LA County Division of HIV and STD Services, and my colleague Wendy Garland from that group is going to be speaking about this project as well, and the collaboration, and also our community partners at AIDS Project Los Angeles, and I see Terry Smith here from that group today, who's been a critical collaborator and partner in this project. The PI of this project is actually Karina Mosharad, who's now at NYU. She was previously here at UCLA. She was not able to be here today, so I just want to acknowledge her leadership in this project as well. So these are my personal disclosures. This study is rooted really in two things. One, the observation that until we address the social and structural needs of people at risk for HIV, as we all know, we're not going to be able to, biomedical things are not going to really get us to where we need in ending the epidemic, and that financial resources go a large way towards addressing some of those social and structural needs. And for that reason, financial incentives could be an attractive motivator to changing behavior. In addition, our colleagues at DHSP, and Wendy will speak more about this, have a compendium of programs that they are using in people living with HIV, some of which leverage financial incentives already. So there's a tremendous interest, as Wendy will describe, in having additional prevention programs that could also leverage this strategy. So the idea, of course, is that PrEP remains suboptimally uptaken and adhered to and persisted with in populations who could greatly benefit from it, both nationally and also here in Los Angeles County, and in specific young people, MSM and Black and Latino populations. So we wanted to understand if a conditional cash transfer intervention for HIV prevention could be acceptable and what it should look like in high-need populations in South Los Angeles. And I want to be fully transparent up front. You'll notice that certain populations are notably missing from that second bullet, right? Trans and non-binary populations are notably absent, and I'll come back to that at the end. We decided that we had to start in a single population where we would not be lumping other important key populations with cisgender MSM, acknowledging that this work needed to be continued and repeated with a specific set of inputs and advice and guidance from people representing trans and non-binary populations before that work could be conducted. So what did we do in this particular study that we called TIPS? Well, we did some surveys that use a discrete choice experiment methodology where we were really trying to tease out what the potential consumers of this intervention might want in terms of both how much money would it take to incentivize a behavior change, how frequently would that financial resource need to be provided, should it be provided as a cash payment or was a gift card-based payment acceptable, and we were wondering also about PrEP type. We also did some qualitative interviews to try and get some more granular understanding of what the nuanced elements of uptake of an intervention like this might look like. You can see in the lower right corner of this slide the demographics of both the qualitative interviews in the right column and our discrete choice experiment population in the left column. I do want to just say that in the background, our thought process was the literature around conditional cash transfers has never been able to disambiguate whether the idea of giving resources to support process, so for example, taking PrEP with an idea that that's going to work to as an HIV prevention strategy versus incentivizing the outcome. So for example, being successful in achieving HIV prevention goals and giving people a menu of options that would help them achieve that goal is the most effective strategy. So in the back of our minds, we were trying to also think about if you were going to incentivize PrEP use, for example, what were the parameters that would support that optimally? And if you were going to support HIV testing, what would that look like differently? Turns out the results end up being very similar, but that was sort of why we broke it up in this way. So I'm going to first show you what we did in terms of the issue of taking PrEP. And the approximately 130 people that we did this discrete choice experiment with, and the results that you are seeing here are willingness to pay translations of the findings. So how much money would you be willing to give up in order for that to be the parameter that, that was part of this intervention. And what we found was that more frequent payments were more attractive than more delayed payments. I don't think that's a surprise to anyone, and certainly the literature supports that closer to a behavioral element, incentivization is going to be a more powerful motivator of behavior change. But it's somewhat dramatic, the willingness to pay differences that we found in this particular study, that people would be willing to give up $345 worth of incentivization to get payments monthly as opposed to annually for the same total cash payment. Fascinating. But the difference between getting it quarterly and monthly was a much smaller number. It was only $67 that people would be willing to give up for that advantage. So we thought that was interesting. There was a slight preference for cash over gift cards, and people would be willing to give up about almost $250 to get the payment as cash as opposed to a larger amount in a gift card. Interestingly, we did not see a difference in preference between daily and injectable PrEP. Now, I think in reality that finding is too premature to hang a lot of information on, because I think here in Los Angeles we've really been struggling, as everyone has been, with injectable PrEP rollout, and there were very few people in this sample who actually had experience with injectable PrEP to date, so it was a hypothetical. And in terms of the amount of money that people would want to support PrEP adherence, now this, again, not a surprise to anyone, more money is more incentivizing. How about that? So you can see that people love the idea of $1,200 a year to support PrEP adherence, and Wendy will talk about, what went into some of the thoughts about what were the right amounts of money to study in this context. And as many of you know, right, if you give somebody more than $600 in a calendar year, then theoretically, we have to issue them a 1099, and they have to report it as taxable income. So that's something that is important to consider in considering these programs. We did break it down by subgroups. I'm going to give you the very top line data here. Right, people wanted more frequent payments. They wanted cash. They wanted more money. People who were current PrEP users preferred cash payment and were less likely to prefer injectable PrEP. We wondered if that's because people like the familiar, and again, they didn't have a lot of experience with injectable PrEP. The younger respondents preferred cash payments and more frequent payments, and our African American respondents actually had no cash payment preference, but they preferred oral PrEP. And we wondered if that had to do also with medical mistrust around a long-acting injectable that had a relatively short set of safety experiences that went with it. So these were our findings with the HIV testing discrete choice analysis. It was basically the same idea. The numbers, the willingness to pay numbers were slightly different. Basically, the people preferred HIV testing, cash transfer support. That was more frequent, that was cash, and was more money. Again, not a whole lot of surprise there. So these were sort of our summary findings here. Give more money, give it more frequently, pay in cash, and there wasn't a strong preference in oral versus injectable PrEP. There was some heterogeneity in the findings based on population, but again, small numbers, so not sure what to do with that. I'm now going to actually hand it over to Wendy to talk a little bit about the context of this project within DHSP's programs and the ongoing partnerships that UCLA and APLA have with the health department. So thanks for your attention.
Thanks. Thank you, Rafi, and good morning, everybody. I want to acknowledge that there are a number of folks here from the LA County Department of Public Health, and so wave your hands or say hi or something, but I'm really excited that they were able to join today, and this has been a really incredible experience that we can take back and definitely apply to our work. Yesterday, you heard from Mario Perez, who is our director for the Division of HIV and STD programs. And we are responsible for the HIV and STD control and prevention response in Los Angeles County. To do this, we have over 200 contracts with approximately 60 community clinics and organizations representing an annual investment of over $80 million. This is supported in a large part from the funds that we get from the Centers for Disease Control and Prevention through our HIV surveillance and prevention grant, as well as our Ryan White Part A grant. We are also one of the 57 priority EHE jurisdictions, and so we also receive supplemental EHE funding from both CDC and HRSA. We've used that EHE funding. It was mentioned yesterday about how we have greater flexibility to use those funds. We've been using that to pilot some models using conditional cash transfers within mostly our treat pillar. So this is an exciting opportunity to see the application of this within sort of under the prevent pillar. We are, as Dr. Weidel mentioned yesterday from CDC, there is a the new prevention funding opportunity has been released, and our office is currently working to put together an application for that, which also includes revisiting and revamping and updating our entire prevention portfolio. So what we've learned from this program, from this experience today has really, or this project I should say, is going to be really instrumental in terms of how we think about updating that portfolio. Where do we include conditional cash transfers? Where can this help leverage reaching folks, getting folks engaged, and helping ensure and promote health for our populations? I would like to say that this collaboration is one of many that we've had with the CHIPS team and also with the TIPS co-investigators. We collaborated with Karina on a project that was also funded by CFAR several years ago before EHE we've developed a microsimulation model to estimate or to test several different strategies to increase PrEP uptake among MSM and LA County. The main objectives were obviously to try and increase the number of people on PrEP, but another piece of the outcome was to try and reduce disparities in HIV incidence through those different types of strategies. So how can we bring greater equity in the way that we are getting PrEP out to folks? And then also, Rafi is partnering with some of my colleagues to implement and develop, I should say, this HIV PrEP project to look at different strategies, including using financial incentives to promote adherence among MSM and transgender women, but also among cisgender women who are experiencing homelessness and also mental health and substance use disorders. So with that, I think, do you want me to move? Shall I move? I'm over time, so I have to move forward. But we're really pleased to be able to continue this collaboration. We have, as I mentioned, it's a long-standing collaboration. There's been a lot of important information that we've been able to pull from this work together, and I really think it helps to continue to build the capacity within the health department to bring these sort of newer strategies around implementation science to help us better understand how do we use this in an applied setting as opposed to just an academic one. So I'm going to move forward. Do you want me to wrap up the slides here? Okay. So the next steps that we're going to take for this project is we're going to be, along with the PIs, are going to be convening a town hall for community partners and stakeholders to share these results, to get feedback, to understand, and sort of provide some more contextualization for what these results are and how we then go forward to try and figure out how do we use this information. As Rafi mentioned, we're also going to be having ongoing discussions with the community about interest to include trans, non-binary, and gender non-conforming people in this work. So how can we get, as he said, more contextual, more detailed information about how we can use these types of models with different populations to be as responsive to their needs and interests as we can, and then also to look into different opportunities for continuing to fund this work and trying to do potentially in multiple sites to see if we can create a little more generalizability of these findings and help us to inform how we can better scale up scale up these types of programs. So thank you.
Great presentations. Thank you all. So we got about 10 minutes for Q&A. Please come up to the mic if you have any questions for our panelists. If not, I'll ask questions. We got one there.
Sorry, Shen Taizhou from UNC Chapel Hill. I have a question for Susanne. Very nice work, but so we're also doing the cluster identification and intervention. When I talk to community partners about cluster identification, I got a lot of feedbacks that they don't want to participate in any of this cluster work, especially when we're trying to incorporate some cluster detection with this testing work. Our community partner says that it will disencourage people to get tested if we include any of this cluster detection in the materials, because people get scared, especially when the the community members don't understand what exactly a cluster detection is. So how do you have the similar issue in Miami, or how do you overcome these obstacles? Thank you.
Sure, thanks for the question. So, so the original EHE supplement was intended to use the phylogenetic cluster data that's already collected by the health department, and that they were able to assemble into totally non-identifiable but general kind of spatial areas where those clusters seem to be happening. I will say that data was very difficult to work with, and we found it much easier to work with more traditional epidemiologic data. There's a lot of missingness in the data. In some places it was very sparse. And beyond the issues with how to go forward collecting additional data, looking back through the data that they had over time and they had already processed and analyzed, it was probably not as helpful as some of the more traditional epidemiologic data at this point. So going forward, we really haven't been using that as much. They've been running it in the background and continue to look at clusters for their own work at the state, and we really haven't focused on that in terms of how we're using the mobile clinic.
Good morning. Tom Giordano from Houston. I have a question for the LA team. Since this is an implementation science-focused conference, we've tried to implement conditional cash transfers, incentives, and maybe the federal partners need to put their earmuffs on now, but we were told we couldn't do it because it's like there's anti-kickback stuff. We can't pay people to come to our center to receive health care. There were concerns about that. How do you do this in a way that doesn't raise those concerns?
That's a great question, and oops, is this on? I can't even tell if okay, there you go. It's a great question, and yes, we have those challenges as well. We actually don't use so HRSA is the main limitation on this, yes. So we don't use our HRSA funding to pay for these incentives. We use additional other funds that we have that we receive. So we have to get around it that way. We can't. It's what we're hoping that we'll be able to do is through these types of projects, demonstrate the utility of this and advocate for changes in that policy, because we feel like right now it's still sort of unknown, not unknown, but we need more evidence to be able to go to HRSA and say this should be supported this way.
Yeah, it's Epidemic, UABG with Pay SSG. I just felt compelled to comment and perhaps call in all of y'all that as a trans woman, I've been sitting here and hearing that transgender people are a risk category. We are not. I'm assuming you all are talking about transgender people who have sex with men. So if you can, in your presentations, put transgender people, TGSM or whatever, transgender people who have sex with men, because I'm not a risk category, just being trans itself. Thank you.
Hi, Jill Blumenthal, UCSD. Oh, sorry. I wanted to ask, this for the LA team, the cash incentives you asked about, was it cash as in dollars or cash apps? And are you asking about that specifically? Because cash apps seemingly have been really difficult to use. And I may be getting ahead of myself because I think we all recognize that cash incentives should work. How do you do this in the long run if it does work? Do you have pots of money from the federal government that you can use? And I think the answer is yes, but I'm curious what you all think about that.
I'll let Wendy answer how you do it, since she's doing it currently. But the hypothetical was cash, not electronic cash.
Creatively is. I mean, I feel like that is part of what we're trying to figure out is like what is the best way to do it. We were doing, for example, one of the models that we were using. We had been giving cash gift cards to clients, like actual hard copy gift cards. But the problem that we were having was that it was very difficult to pair the behavior with the incentive. Like, in fact, it would be like a month or 2 months before someone could actually come pick up the card. So we changed that to being able to use digital gift cards and using a web-based system, or an online system that we have that can help us. Clients can enroll, and then we can send them text messages to check in with them to see how they're doing. And then based on the information that they report to us, when they're responding to the text messages, as well as the data that we get from our surveillance system about whether they're achieving viral suppression or not, then they get gift cards sent to them electronically. So I don't know if that helps. Yeah, we haven't used just cash, but.
That's what people want, though, of course.
Yeah.
Right? Thanks.
All right, we're going to take one final question, and the panelists will be available during break if you're interested.
Sure. Naina Harawa from CFAR and CHIPS at UCLA, and Charles Drew. My question is for Stephen. I was really interested in your training and the fact that you had this 50% take-up rate or response rate. At the same time, you had so many trainings, and I could see many of them probably people maybe didn't need. And so I'm wondering, did you think instead about maybe doing like a pre-test and then assigning people to the trainings that might make the most sense for them? That's my main question. The other one is, how did you get so many leaders to do the training? I actually think it's quite an accomplishment that you had that many people in leadership actually do the trainings.
Yeah, thank you, Nada, for those questions. So actually, I think I listed 24, 25 trainings up there. They were not all assigned to all people, but many of them were assigned. And so, yeah, I think that is probably a great adaptation going forward, is to think about, can we do a little bit of work with folks beforehand to see, oh, maybe you've worked in this field for 10 years, you don't need HIV 101, And then I think the counterpoint to that is also, we need to develop advanced trainings. I think that was the idea, that these were more nuanced, more in-depth. But I think what we learned from this was that we need even more nuanced and even more in-depth to kind of continue to build those skills for folks who have been in the field for a long time. About the agency leaders doing the trainings, yeah, I think that part of that speaks to there's a lot of buy-in. They've worked with the health department and with us at Penn Nursing a lot. And so I think they said, yeah, we'll do your project with you. And as we were really glad. I also think, and this is totally a hypothesis, but I wonder if we got a little bit more honest responses from the agency leaders. And they were the ones who said things, they didn't like the trainings quite as much, but I'm wondering if they kind of felt a little freer. The power dynamics are a little different. And so I'm really glad that we had their voices in that collection.
All right, thanks again to all the panelists.